Good afternoon. Good afternoon, everybody, and welcome to Psychiatry Grand Rounds. My name is Tony Rothschild. I'm the chair of the Grand Rounds Committee. A couple of brief announcements. Grand Rounds will continue in person and on Zoom. Lunch is provided if you come in person. To receive credit, please complete the evaluation that was sent with this on the survey, the evaluation on the Survey Monkey that was sent with the Grand Rounds announcement from Karen Lambert this past Monday. This applies to whether you are in person or are attending on Zoom. This will change soon as the CME going to have a new procedure, but I will remind you of that when it happens, and you will receive announcements about it. For those of you on Zoom, please type your questions in the chat. And as a reminder, the department provides touchdown space if you need an office, either just before or just after Grand Rounds. Next week's Grand Rounds will be given by Dr. Gina Lynn Mooneyham from the National Institute of Mental Health, and the title of her talk is Autoimmune Encephalitis, Immune Regulation and Psychiatric Symptoms. And the week after that, we will have Dr. Robert Waldinger from Harvard. His title of his talk, What Actually Makes Us Happy? Lessons from an 85-year longitudinal study of life. It's my pleasure to introduce Dr. Sheldon Benjamin, the Vice Chair for Education, who will make a few remarks and introduce today's speaker.
Thanks, Tony. So welcome to the second annual John F. Sullivan Memorial Lecture in Neuropsychiatry. I think most of you know this, but John was he was a student and a resident here. When he was a second-year UMass Chan medical student, when he approached me after a lecture to ask me the first of all of the unanswerable questions that he tended to ask, but they were fascinating. And he never did stop asking those questions. 2 years later, he entered our 6-year combined neurology psychiatry program to begin searching for answers himself. Upon graduation and a 5-year dalliance with Brigham and Women, which we forgave him for, John returned to UMass Chan and ultimately became not only a favorite teacher for our residents, but became the medical director of one of our inpatient psych units, 8 East, one of the main teaching units. In June of 2022, when we lost John to cancer, his wife, TC, expressed John's wish that a memorial lecture be created in his name. So we had a conversation at that time. And today, I am thrilled to announce that due to the generosity of John's family, friends, colleagues, other residents here in the department, our neuropsychiatry alumni, the Sullivan Lectureship was able to reach the endowment level of $25,000 this year, which entitled us to... It gets better. That entitled us to approach the state for a 50% match, which they then are providing. And so the fund is now at $37,500. As we raise more money into this fund, we're going to expand what it can do for neuropsychiatry education. So if you'd like to continue giving to this, and we hope you will, it's just the UMass Chan, foundation, and just specify the Psychiatry Sullivan Memorial Lectureship, and it'll get to the right fund. So our speaker today served as a co-resident in neuropsychiatry with John. Ankur Butala graduated from the physician scientist bachelor's of science medical degree program at Rensselaer Polytechnic Institute with Albany Medical College. He then enrolled in our 6-year combined neurology psychiatry residency program, the same one that John Sullivan graduated from. Ankur likes to always do more than one thing at a time. So during his residency, Ankur went to London to study functional imaging. He went to Gainesville, Florida to study movement disorders and got hooked on it. So after 2 years as a neurology and psychiatry locums, which he calls being a mercenary, he then spent 2 years as a clinical fellow and 1 year as a research fellow in movement disorders at Johns Hopkins, where he has remained as an assistant professor of everything, psychiatry, neurology, some other damn thing. What was it? Yeah, lots of titles, and where he sees patients with movement disorders and does research on them. He's written a number of papers, but my favorite recent paper was called something like Parkinsonics. It was a controlled trial of group singing as a therapy for side effects of Parkinson's disease. Fascinating. So his email signature describes him in ways much more poetic than I can. So you brought this on yourself. He describes himself as a sawbone shaman of shakes, an ataxia apothecary, a hyperkinetic higgler, the doyen of dendrites and feelings, the viceroy of vesicles, the sultan of synapses, a prefrontal pundit, and a dopamine diplomat. I guess that kind of sums it up. I want to extend a special welcome to Dr. Sullivan's wife, TC, his adopted mom, Maurice Sullivan, and his neighbors and friends who have continued to support this lectureship and came to see Dr. Butala today. TC knows Dr. Butala already. And to celebrate John Sullivan's life by continuing to teach neuropsychiatry. Ankur, I invite you now to come up and receive the John F. Sullivan Memorial Neuropsychiatry Lectureship Award. And we're very much looking forward to your talk. We've got the plaque here that says, UMass Chan Medical School, Department of Psychiatry. Turn it this way so they can see here. The John F. Sullivan, MD, Memorial Lectureship in Neuropsychiatry, presented to Ankur Butala, MD, October 12th, 2023.
Thank you. Thank you very much. So, thank you, Sheldon, for your kind words. Can everyone hear me okay? Yeah. Okay, great. I remember John fondly, and I'll just mention one story. The first time I was on Neurology Call, the first time I ever administered TPA, John was my backup. And I recall walking into the emergency department and seeing someone with a functional neurological disorder like this, and how John and I looked at each other and we administered TPA anyway. The person was fine and was discharged the next day. So John will be sorely missed. So I'm here talking about innovations in treatment-resistant schizophrenia, specifically focusing on deep brain stimulation and precision medicine. These are my disclosures. I have no specific conflict of interest as it pertains to this presentation. By the end of this talk, I hope we can all review recent advances in neuromodulation, especially as it pertains to psychiatry, with a particular focus on DBS. We'll be looking at novel biomarkers of psychosis, specifically derived from local field potentials, which I'll explain a little bit later on, as well as some of my primary work, research work in digital biomarkers. We'll evaluate methods for optimizing and personalizing deep brain stimulation as it pertains to psychiatry. And then, we've published our first case, but I'll be going over two other cases that have had DBS for schizophrenia implanted that we have not published. So this is hot off the presses. So a little bit about the scope of the problem here. The WHO estimates an overall prevalence of schizophrenia at about 23 million persons, which is about 1 in 300. We're estimated at 0.32% worldwide. And despite the number of first and second generation medication available, 20 to 50% of persons may not have an adequate response and have some degree of treatment resistance. And clozapine, despite being our best antipsychotic, might leave a fair number of people with persistent symptoms. And so if we narrowly look at treatment resistance generally, and this is from Kennedy et al. In 2014, the cost is estimated as 3 to 11 times greater than schizophrenia, something in 2014 dollars as $34 billion annually. And so what part of the issue is what is treatment resistance? This is relevant to the subjects I'll later review here. In 2017, the Treatment Response and Resistance in Psychosis TRIP working group attempted to come up with a consensus definition of what the heck treatment resistance actually means. And so they looked at all the trials that were studying schizophrenia at the time and whether this was number of antipsychotics used, were they from different classes, what was the duration of therapy, and so on. And in short, they came up with this in the bottom line breakdown in comparison to some other guidelines for the definition of treatment-resistant schizophrenia, which in short is a failure of at least 2 classes of medication. Generally, we conceptualize this first and second generation at least. The TRIP definition included a depot treatment of one kind or another for at least 6 weeks in duration. And so A failure was defined as either a less than 20% symptom reduction in any prospective trial. So that's the yardstick that we're trying to overcome with deep brain stimulation, is that minimum 20, better than that for at least 6 weeks, with being able to adhere to treatment for at least 80% of the time. And so with that being said, I'm going to review our first case, the one we published. So this is a 36-year-old woman with schizophrenia. Schizoaffective disorder was also mentioned in her chart. Has concurrent obsessive compulsive disorder, tardive dyskinesia, pituitary microadenoma, and had some degree of akathisia, which you're going to see in the video. She also had a functional neurological disorder. She had episodic weakness in the past. This was confirmed after continuous EEG monitoring. Remote history of 20 plus suicide attempts. Many of these were to quiet her hallucinations. She lives in the Midwest with her parents and a child, and that was her medication that she was on at the time. And so I'll leave that up for a second. And I don't think anyone would dispute the fact that she's treatment resistant based on the number of other medications that she had tried in the past. Right. So here we're about to see the video. So she was hospitalized in January 2020, which is relevant for a number of different reasons. We are electively hospitalizing these subjects for about 2 weeks or so they can have their surgery done. And so she had just surgery placed. She had a Medtronic 3387 lead placed with an Activa PC, which is a non-rechargeable system. Unfortunately, COVID started right around that time and led to a lot of issues with follow-up. In our initial first visits, the electrode had, quote, high impedances, which basically meant we weren't sure how effectively stimulation was being administered. Unfortunately, I don't have video of her from before the leads were implanted. This is relevant because in many DBS situations, the placement of a lead causes a temporary improvement of symptoms. So what you see here may not be accurate of her actual baseline.
I'm fine right now.
Tell us about the hallucinations.
They're gone.
Totally gone.
Yeah, totally gone.
Okay. And
Like they never even existed.
so I'm going to slowly back down
All right.
and just tell me as soon as they start recurring. Okay. All right. So 1.45, 4
All right.
here.
Yeah.
Tell just now.
Just now.
And what are they? Can you describe them?
They're like whispering sometimes, but then there's some that are yelling. Like they do not want me to get this done. They know. I told them.
So how about now?
What do you mean?
Are they still there?
Yeah.
Gone?
So we were dumbfounded. She had spontaneously blurted out the voices are gone. I mean, I just tried to turn it on and she just blurted out they're gone. And so but we weren't sure. And so we did some additional programming.
How do you feel right now?
And
I
so
live in New Jersey. I feel really better. I feel really happy and not confused and not weighted down. It just feels so much better. It feels like I can do anything now. I feel a little euphoric.
So we were a little concerned by that comment. Again, this is the first time this location had ever been stimulated. So we weren't sure what would happen. And so we saw her in follow-up a number of times afterwards. And the next slide I have here is 8 months after we have continuous stimulation. On the right, you can see her deep brain stimulation leads here and here. This is a substantia nigra pars reticulata. And so what you're going to see is her description of how she's been since surgery.
Do you mind talking about how you're feeling now with the DBS on compared to
Everyone can hear okay?
before?
I think it's much
is there a way
better
to-
because I don't hear voices, so I can concentrate on things and I can notice things I never noticed before. And I can be more active in my daughter's life and in my life.
Right up here. Great. Because it would be important to hear her response because I think that drives a lot of the improvement. So
I'm fine.
I'm just going to skip to this one.
Do you mind talking about
better?
how you're feeling now
Too loud?
with the DBS on compared to before?
I think it's much better because I don't hear voices, so I can concentrate on things and I can notice things I never noticed before. And I can be more active in my daughter's life and in my life. It's just a lot better.
Do you feel, do you ever experience voices of any kind?
When?
Anytime? Now?
Not now, but like before I did, like every day, every minute.
You noticed that change immediately or right after the DBS was on, or?
Probably pretty soon. Or right away, depending on the situation last time, however it was done.
Do you think your mood has changed
Oh yeah,
now?
my mood's
compared-
been a lot better.
Can you talk about that a little bit?
Well, I'm happier because I'm not so crazy, you know?
Mhm.
I can go around, and even my therapist said that I'm like a normal person now, so I gotta get used to that.
So the degree of her response really just kind of kept us going and kept us kind of pursuing this further. So I'm going to step back a little bit and now talk about a survey of neuromodulation techniques. And so between 1997 and 2020, Elias et al. Reviewed 1,252 different techniques in neuromodulation. This is generally any non-pharmacological, any non-psychotherapeutic way of affecting brain circuitry of any kind. And of these, a third were completed, 56% were, 54% were active or were recruiting or non-recruiting, and a number had been withdrawn or suspended for one reason or another. And so one of the main reasons why I actually did a movement disorders fellowship is that red line overlaps with my time here at UMass. And there's like an inflection point of neuromodulation right after that. So whether for the trainees in the room or the students, it may not be necessary to spend 2 to 3 years in training after a residency if you're interested in neuromodulation anymore. Maybe it seemed like that way at the time. So anyway, so most of the indications of neuromodulation are depression. This is 45% of persons with schizophrenia being number 2. And then there's a number of other disorders in play. So if anyone's interested in research in this space, this is just sort of to give you a sense of the lay of the land. In terms of what is actually done, so non-convulsive, non-invasive therapies stand the most common neuromodulation therapy. This largely consists of transcranial magnetic stimulation or the various transcranial electrical stimulation, so direct current stimulation or nodal stimulation. This is followed by convulsive, non-invasive stimulation, this is ECT, as represented over here, and then magnetic stimulation therapy here in the corner. And then what our talk is about is this invasive deep brain stimulation, which is about 10% of the available studies, followed by vagal nerve stimulators and other superficial, more cortical stimulation. And it's by virtue of the majority being TMS and TDCS that the targets are generally cortical. So there appears to be a bit of cortical favoritism, and the DLPFC, medial prefrontal cortex, various temporal, parietal, occipital cortices are the most common targets. Instead, what we're talking about is deeper brain targets. And of these, a lot of this is done in depression and OCD, which I'll cover a little bit later. So the nucleus accumbens and ventral striatum. But we're here in this other deep structure. So it's a fraction of a fraction of a fraction. So when I just want to preface that I might not be able to explain how the heck this whole thing works yet. And we haven't quite figured that out yet. And I have nothing else to reference as to how it works. So. All right, so looking at one of the reasons I was gravitating towards DBS rather than other neuromodulation techniques is my sense of the effect size was greater. It's more potent an intervention than TMS or TDCS or so on. And so this was looked at by Rasan et al. Comparing 102 meta-analyses and trials. So what is the efficacy of these different neuromodulation techniques? And they did this in 2 ways. They looked at a standardized mean difference, that's in the x-axis on the bottom, towards our right favors intervention. And the plus marks are the certainty of the results based on various parameters of the trial. And so for any depressive condition, this is both bipolar and depressive condition, unipolar depression, actually theta burst stimulation seemed to perform slightly better than ECT, but you can see the confidence interval is there. So for the ECT advocates in the room, I mean, I wouldn't necessarily buy a theta burst stimulator already. And I have to defer to others in the room who might know more about that specifically. That's followed by TMS. But if we look at narrowly at treatment-resistant depression, so excluding the bipolar depression, this is where DBS's effect really starts shining. And this is even more true with obsessive compulsive disorder, in which the standardized mean difference is effect size is much greater at 0.89 compared to TMS, which is down at a 0.64. And I'm going to elaborate on each one of these. So now I'm going to go over a second case. So this is not published. This is the first time people are hearing about this outside of at Hopkins. This is a 44-year-old woman with schizophrenia. She also had obsessive compulsive disorder mentioned in her background, which is interesting. PTSD, akathisia. She had psychotic symptoms. She was 12 years old, was under treatment since she was 15, had remote suicide attempts, largely from her command auditory hallucinations or because she was having dysphoria from the hallucinations. So she was depressed by that. She had a lot of delusional guilt. She was concerned that she was the cause of a lot of these things that were going on around her. Had a number of hospitalizations, remote self-injurious behavior, lived in the mid-Atlantic, and this was her her most recent medication list as the time of enrollment in our study. Again, I don't think anyone questioned that she's treatment resistant based on the number of medications she's tried in the past. And so this is her first. So she was hospitalized in January of 2022. Again, we do an elective 2-week hospitalization where we do the preoperative labs, we do special MRI with tractography, we do the neuropsychological evaluation, and then the neurological signals is my research protocol for digital biomarkers, which I'll cover a little bit later. So then they have the stage 1 surgery. And so this is she again had a non-directional 3387 lead. And then had a newer device. The stage 2 is a Percept PC, which importantly for later on allows recording of physiology. And so this is her preoperative baseline. And so she's going to talk about her hallucinations here. And you might see some psychomotor activation, some akathisia here.
I hear voices. Apparently, yes. Apparently I have illusions, which I was not aware of. I've heard voices since I was 12. The one I remember best is Lazaro. And that's the one I got up to 900, either 900 or 1,000 milligrams of toxic on.
And so she developed toxicity on that. So we're going to get back to her in our third case. I'm just keeping these videos scattered throughout to keep people interested and from falling asleep. So, all right. So a little bit about the history of DBS. So deep brain stimulation is an extension of lesion-based surgery. So this is from the 1940s. Before you're going to put a wire somewhere, you have to be very confident it's going to get to the target accurately. And so it requires a frame or a torture device attached to someone's skull, which I'll show pictures of later. The first lesion studies in Parkinson's were published in 1950. As you're doing DBS, you put a wire in, especially in the pre-MRI, pre-CT era. You put a thin wire in and listen to the firing of the brain, and then you might emit electricity to confirm that you're in the right target. And so this was described in 1963 by Fassard with high-frequency stimulation. Then around 1969, levodopa came out, and sort of any interest in ablative surgery sort of plummeted like a rock right after that. And so it wouldn't be until about 15 years later when Alain Benabid in Grenoble, France, first published and internalized the system. So put the wires in and then connected to a pacemaker device, like a cardiologist would use basically under the chest. And so thus DBS technology was born. And then in 1991, there were reports about thalamic stimulation in Parkinson's and central tremor. In 93 is when the first reports for ST and DBS in Parkinson's arose, and then GPI stimulation shortly thereafter. And so between 1996 and 2017, this is data from the United States. Sarika reviewed 105,000 hospital discharges for deep brain stimulation. And this is just, we're talking about psychiatric indications, but you need to get a perspective of what the neurological volume is. So when we say we're comfortable with DBS, this is why we're comfortable with DBS. The majority were for Parkinson's, essential tremor, and dystonia. If we look at OCD volume, at most, it was maybe 30 cases a year. As for depression, from 2002 and 2011, and so I was here at UMass. I was a programmer on the Broaden study, and I think that includes some of these cases here. The total of 95 persons with depression that were implanted at that time. And then AJ Majan and I did an international survey of all the DBS centers to get a sense of like what is the lay of the land. And there's a wide interest in psychiatric indications, but there are narrow centers that sort of are oriented towards doing it. A lot of these are from the neurological centers. The neurology centers are like churning through DBS cases like, okay, we need to do more. Where else can we expand? And so it's not really driven by psychiatry, at least that's our perception at the time. And so the case volume that we generally see internationally is between 10 to 200 a year. I think one Chinese center was estimating 300 a year. I'm a little skeptical about that one. But the average for the United States is somewhere between 50 to 100 cases a year. And these are decisions that are not made lightly. We have a whole multidisciplinary committee, neuropsychologists, psychiatrists, neurologists, the neurosurgeon research team. We have discussed every single person's case to say, is this a good idea? Should we proceed? Are we missing something before we put the lead in? And I think at least 50% of the centers that do this sort of work have that similar approach. So we want to make sure we're doing right by them. So when I say it was a torture device, this is what I was illustrating. This is the patient would be here. This is the frame attached to their head. This is a C-arm with the driver. I'm not as familiar with this frame as this Lexell frame, who Lexell did some of his initial work in obsessive compulsive disorders. And I remember being a fellow wedging myself between an intraoperative CT scan with a little dental mirror, trying to look at these little hatch marks to identify the position of the frame and not jostle it. So we had to like reposition or rescrub. So it was good times. Nowadays, though, we use a robotic assistant. This is a robotic surgical frame, which sort of uses an electronic grid, although we might still do microelectrode recording where we thread a wire through various aspects of the brain and we listen to firing patterns of various cells to kind of confirm where we are. Now, around the past 4 or 5 years, intraoperative MRI technology has come out. And so this is illustrating an MRI that's literally wheeled into the operating room. And so I think nowadays, 50% of our neurology cases are done through intraoperative MRI, patients under general anesthesia, and 50% are done through a frame-based. From my perspective, having the patient awake and getting the physiology is important because that way you know where you are, like truly, you don't just have a snapshot picture as you might have with an MRI. The MRI is more comfortable for the patient. The surgeon prefers it because surgeons never want anyone talking during the case, but you don't find out how effective it is until a month later when you're turning the system on. So this is our third case. So again, not previously published. So this is a 39-year-old guy, actually from New England, with a diagnosis of schizophrenia. He also has akathisia for some reason. He had a remote history of polysubstance use, alcohol, remote cocaine, cannabis, was hospitalized at least twice, and was diagnosed relatively late in his 30s. He works in HVAC and was married with children, again, in New England, and this was his medication list at time of initial enrollment. He also tried a number of different medications before. So again, I don't think there's any question that he's, definitely treatment resistance. And so he was hospitalized in September 2022. And so I was out of town when he had his hospitalization. So I don't have a baseline video of him. And so the video I have of him is before the system was turned on, but again, after the lead was placed. And so again, it may not represent the best example of his true implantation baseline. He also had the newer system placed. We did what's called thresholding in this visit, we'll explain later. And he's accompanied by his spouse and his psychiatrist who was interested in seeing what this whole thing was about. And so just keep the fact that this might not be an accurate baseline in mind.
Right now, it's quiet. I mean, like, if you guys all talk, I won't be able to hear them. But when it's quiet, and I'm always by myself, I work by myself. I'm at home by myself with a kid all day. So I'm always in places, I'm in basements and attics. I work.
How about right this moment?
Right this moment? Yeah, they're talking.
0 and 10. 10 is the most intense.
That's my colleague, Nicola Casella.
Yeah, see, they're talking right now.
So 10 is the loudest you've ever heard.
It's not loud right now. They're not loud, but I hear them.
Give us a number between
Okay,
0
7.
and 10. Okay.
And so I have another video that might better illustrate what his baseline is. So after we had stimulated, he had a period of breakthrough psychosis, which I'll get back to later. In the interim, his spouse had said there was maybe some modest improvement in his overall functioning. He had sort of gone back to work. But he had been attempting to make adjustments to his stimulator at home. We provide them with a home programmer because they're traveling long distances and sometimes we need to troubleshoot. Is there an issue? Does it need to be escalated? His psychiatrist had wanted to try to see if he could help with, remote programming as well. So that's why he had one of these. In retrospect, we later learned that he had relapsed in some substance use at the time. So that might've been part of the context of why his symptoms had amplified. And it may be because, despite what we tell them that we can't promise miraculous instantaneous results, people still feel that. And so if we don't administer that, they get dissatisfied. So that might have been part of it.
I never there. I did it myself. I try to. I mean, I can hold it off, but it's more of a keeping them quiet. I mean, just let them talk, and I talk a lot. It lets me stress myself. It lets me speak.
Yeah.
I mean, me hold it like I go out and hold it in. I'd rather not do that. I'd rather just go home
And talk.
It goes on every day.
Yeah.
I woke up at 6 o'clock this morning.
Yeah.
And right there. Boom. Second I woke up.
And they talk
All day.
all day, and they talk all at once.
Yeah.
Or,
I talk about my dreams with them. They're like, hey, what your dream last night? And they know exactly what went on with my dream.
yeah.
They know what I think. And they still don't say, I'm like, you're in my head. And they're like, no, I'm not.
Yeah.
And I'm like, yeah. Okay. Everything goes to it.
Nice.
Nothing goes out of it. It's like not even a question where they are. They don't know where they are.
So We're going to get back to him a little bit later when we turn the system on, we can see his response. So what is a prevailing data thus far in at least 2 indications, depression, obsessive compulsive disorder? So since Mayberg's first report in 2005, the subgenu of the callosal region, specifically anterior cingulate cortex, is now one of many sites as illustrated here. Ventral striatum, nucleus accumbens, lateral habenula, medial forebrain bundle, stria terminalis, uncinate fasciculate, STN, a bunch of different things. In fact, I think the STN was among the first reports of DBS in to address mood. They were doing DBS for Parkinson's disease and had stimulated in the ventral STN, and the person became manic in the operating room. And then you reduce the stimulation, the mania disappeared. So, looking at the subcallosal region target, the only other one that the longest follow-up was the medial forebrain bundle, as reviewed here by Beverwick. And so they looked at 8 persons over 4 years of follow-up. And so they defined a response as a 50% reduction in MADRS. It's a pretty consensus normal way to address that. And a remission is a less than 10. And as you can see illustrated quite nicely in this acute, precipitous drop, it was a rapid 75% response in that stayed at 12 months, so 6 out of the 8. 50% had hit remission, and this stable effect was present for the majority of the time. And for secondary outcome measures, they used the Beck Depression Inventory, HAM-D, as well as the Beck Depression Inventory and the HAM-A. And you can see similarly significant drops in scores at this time. Now, it's relatively close to the oculomotor nucleus or fibers that sort of are nearby there, and so a fair number of people had strabismus, blurred vision, and headaches, and so that's one of the limiting issues with this specific target. As for the subgenu of the callosal regions, or anterior cingulate cortex, this is the longest follow-up study that I was able to find. So Cromwell reported on 28 subjects, 14 of which had made it through all the way to 8 years of follow-up. And they defined a response as a 50% reduction in the HAM-D. Remission is less than 7. And they use a slightly different measure, which is the illness density index. Essentially, when you're doing any behavioral scale, there's a recall bias, right? So the persons will remember the recent events that might skew results. So the illness density index is the area under the curve of any given behavioral scale for a time point. So they thought this was a better way to kind of demonstrate improvement over time rather than just a pure numerical readout of just the score. And so overall, the result was a HAM-D reduction of 50% by about a year, with ongoing response from year 2 on, with 30% of subjects hitting remission. And interestingly, the 4 out of 5 people who withdrew, most of them had bipolar depression, which is also, it seemed to be more liable to the adverse effects. So the adverse effects are relatively high. So 50, and one of the issues is that, once you start getting an adverse effect, it kind of keeps rolling. So the person with the intraparenchymal hemorrhage also had like an infection in the IPG, also had like a lead fracture, also had complications thereby. So that might skew some of the numbers of the adverse events. And as well as a number of suicide attempts. And again, most of these suicide attempts were in the bipolar depression cohort, and generally within the first few weeks or months of when the stimulator was turned on. And again, maybe that's to do with that expectation of like effect. Like you didn't get as much out of it as you thought it might do. So when we look at the subgenual callosal region, it appears to be the most effective. And so this chart here is cumulative analysis, of course, of several studies that are looking at follow-up up to 24 months. And in general, you're looking at 2/3 to 76% response, with anywhere from 37% to a 63% remission rates up to 24 months out. So that's pretty good. Again, these are treatment-resistant depression patients. And so when you look at, but the caveat is this data includes a lot of open label or relatively short-term studies, like 6 months. So how much can you actually conclude long-term of this target? When you look at cumulative analysis across all the brain targets, there are more modest outcomes. And so this is 1/3 of people achieve remission, 1/3 are improved, and 1/3 have no benefit. And this is a takeaway point for any trainee in the room. When anyone asks you what the effect size or the incidence of anything is, just guess 1/3. It's served me well through the entirety of my training. So, shifting gears to DBS for obsessive compulsive disorder. Again, a lot of this initial work was done through capsulotomy in the 1940s and 50s. It wasn't until 1999 when Nutten reported the first outcomes of anterior limb of the internal capsule DBS, and the FDA issued a humanitarian device exemption in 2009. And so since that time, there are a number of different brain targets, the ALEC, the nucleus accumbens, STN, and largely targeting the proposed network of impairment that arises in the unique cases of obsessive compulsive disorder, whether someone hoards more or has hyper-religious ideation and so on. And I'm not going to spend further time kind of outlining why. So how efficacious is DBS and obsessive compulsive disorder? So I think this is best illustrated by the chart here on the bottom. These are the Y-box scores, and you can see how they evolve over time when stimulation was started. In essence, reading 60% response, 42% reduction in Y-box scores over 12 months. And in this series, there were only 1 of 30 had serious surgical complications. Again, there was a fair number, a third had OCD worsening, and there was debate of whether this was actually attributable to stimulation or not. And so I don't know, there's no consensus on that yet. The seizure number of 13% is higher than I would like, and I'm not sure I can explain why it is as high. It was mostly perioperative. And it may be that, these reports are from a long span of time, and how we approach surgery has evolved considerably. So whether we don't nearly see, certainly in neurology, similar adverse effects rates. Denis et al. Reported the largest follow-up study that I was able to find on the ventral ALEC in obsessive compulsive disorder on 70 persons, again, between 2005 and 2017. And their response measure was a 35% reduction or greater in the Y-box. Non-response was less than 25%, with secondary outcomes being based on the HAM-A and HAM-D. And again, they saw a rapid 40%, 14-point reduction on the Y-box with similar rates in the HAM-A as well as HAM-D. And, generally hitting 50% response, 31% non-response, but this sort of very rapid, immediate effect of the stimulation, which generally kind of persisted. So what you see up front is sort of what you might get, barring optimization of stimulation. And again, the adverse events rate is higher than I would like. And again, I can't explain why it's that high, but DBS evolution practice has evolved considerably since 2005. So a number of these are lead positions, so needing lead reposition or infections with 3 suicide attempts. So when you look at just the randomized controlled trials, so these are the just looking only at double-blind placebo-controlled trials, the rates are a bit more modest. In the blinded phase, we see a 22 to 44% reduction in the Y-box. But in the open label phase, we see up to 75% improvement. And part of this is because in the open label phase, often the subjects start CBT again. And so CBT adds an additional 5 to 10 point Y-box reduction. So we're not saying DBS replaces everything else that people do. It just adds onto it, right? You just add it to your toolkit in your armamentarium. So what about the different heterogeneity across the studies? So given all the targets and things, so we can look at this, is there heterogeneity? What is the cumulative effect? So we can look at the box and whiskers plot on the left, and this summates the data across 31 trials, a total of 345 subjects, on average showing a 14.5% reduction in the Y-box. Then what about how much of this is actually accurate? Is there variability because of the lead position and how outcomes are measured? And so we use the funnel plot on the right to do this. And the x-axis at the bottom is the mean reduction of the Y-box. So you ideally want to be on the bottom right. And the error rate, standard error rate, is on the Y-axis. So you have a greater error rate if you're towards the bottom left, with the dark green area being a p-value less than 0.05, the green being 0.01 to 0.05, and the light green being less than 0.01, so fairly significant. And so removing the trials that were not able to provide the data sufficiently for the secondary analysis, we had 249 patients with an overall treatment effect of 47% in the Y-box reduction. This is a response rate of 66%. And the only trial that did not have significance here is this one. Chose one of the outlier targets, the medial dorsal nucleus of the VA nucleus of the thalamus. So what can we conclude from this so far? So DBS can, at least across multiple sites, is capable of exerting a robust and rapid effect. But the site selection alone, either in where the procedure is done or the location of the brain, does not guarantee results. And most of the adverse events are transient, but many subjects in the depression and OCD chose to continue. Like, it didn't matter that they had adverse events. The benefit was so much better that they wanted to continue it anyway. And that when you're looking at adverse rates, keep in mind that one unfortunate person's outcome with DBS can skew the incidence of the adverse effects rates. It's worth keeping that in mind. All right, so with that, I'm going to touch upon the prior work in DBS and schizophrenia specifically, and then we'll get back to our cases. So This is a group out of China that reported habenular DBS in 2 subjects over 12 months. They thought the habenula would modulate dopamine and serotonin. Their subjects were noticeably younger than ours, in their 20s, and a relatively short illness duration overall. This is the modeling of where their lead was. So this is the lead. The red is the volume of tissue action. So what we expect the amount of stimulation area to be, with the darker blue structure being the target in the habenula. And they didn't have really great results. One case responded by 6 months, which persisted. The other case, it appeared to worsen. And so the limitations are, they turned it on. These people are acutely ill, and they turned it on. Whereas all of our subjects, they were not, they had schizophrenia, but they weren't decompensated. They were, as stable as they could be outpatient when they had their surgery. They used oddly low stimulation settings, which doesn't really make sense to me. And I was a little bit skeptical over the lead position overall. But a larger group was done in Barcelona, where this group was had a lot of experience with DBS for obsessive compulsive disorder and depression. So they used the same targets, the nucleus accumbens and the subgenual anterior cingulate region, and said, well, how does it work in a different disorder? And so of 8 subjects, 1 had a hemorrhage and had to have his IPG, the pulse generator, removed. And so this is just 7 subjects overall. And so they programmed these people to stability, then randomized them to a stim off or stim on period, and then with a crossover. And so this was all done under general anesthesia. For some reason, they were activated very rapidly. We generally wait a month after it to give the brain time to recover and heal before we turn it on. But so they decided to activate right away. And so what they can see is, and it might be because of they turned it on right away, they didn't see improvements for 2 months out, which is part of why we wait. We wait a month, then turn it on, because we want that lesion effect to dissipate so we can see the real change. They did see an improvement of some degree in 75% of their subjects having a response in the PNS scores in the 2 different regions, the nucleus accumbens and the subgenu of the anterior cingulate. And in this follow-up study, there were persistent benefits in the responders for up to 3 years. And so the cumulative data of all the subscales up here. But what are the issues with this? Is that they all had persistent psychosis. So all of the subjects have continued to have hallucinations. They didn't really reach significance in the reduction. So there wasn't like that much of a response. They were not able to adjust the psychiatric regimen at all. This was also open label and unblinded. The stimulation parameters were fairly high. And in the DBS realm, the more electricity you are dumping in a region, the larger the field you're emitting. So what are you actually targeting? That's the question. So when you're administering smaller amounts of electricity and you're getting a better result, you generally think, okay, I'm closer to the node, the lever that has to be moved to exert the best benefit. And so when you're giving this much, you wonder, like, is this actually that precise? Is there a better place that could be administered? And again, the 1 out of 8 with hemorrhage was relatively high. And it may be because the target is very close to the ventricles, and the ventricles are these thin veins very close to it, and we generally like to stay away from the ventricles in Parkinson's disease to minimize hemorrhage risk. So now we're going to talk about our clinical trial, and anyone who's interested in looking at it, or as a subject who might be interested, feel free to scan the QR code here. I'll leave it up for a second, and then I'll bring it up again later on at the conclusion of the talk. And so in brief, we were looking at people who were very resistant. So they had to fail clozapine. So they had to fail 2 antipsychotics. The antipsychotics had to be among different classes, more than 12 weeks. We converted dosing to chlorpromazine equivalents. They had to get at least 500 milligrams of chlorpromazine equivalents. They had to have tried clozapine for up to at least 400 milligrams for at least 12 weeks, or have been demonstrated intolerable to clozapine. So these are definitely treatment-resistant, clozapine-resistant persons, hitting at least 6 on brief psychiatric inventory rating scale for positive symptoms. They had to be ambulatory. They had to have capacity. This was independently assessed by someone not involved with the study team. And they couldn't have been using substances. And one of the important things is, a lot of our subjects have to travel long distances. So they have to have stable psychosocial situations. They have to have a loved one who's sort of involved in their care. And so this is the outline of the first subject. Red is the total positive symptom score. Yellow is their hallucinations. Right after surgery, you can see the drop in the hallucinations with a bit of a rebound, and the substantial drop after stimulation was optimized. So she had the best overall response, and we could see maybe a slight trend towards decreasing in their negative symptom score too, which we were somewhat surprised by. But she had the best of all of the other cases. So now we're getting to our thresholding. We're back to our second subject. So in this, we did physiology, which is we did a brain sense survey. We did a monopolar review. So we stimulate each contact on the electrode, as you can see here in the bottom here. So we stimulate a field and we see what side effects this person gets. And she was reporting how she was feeling on a Likert scale. You're going to see prominent rocking and finger snapping, which seems to happen when her psychosis is back. And then she had some stimulation related double vision.
Nine. Okay. How's your mood? How would you describe that?
I'm nervous.
Okay.
I'm trying.
Just as bad?
Might be a little less.
How's your anxiety? On a 0 to 10 scale?
It's a 9.
9?
Yes, sir.
And the sort of concern about what's going on outside? 10 out of 10 still. Hallucinations?
So they are down. They are less loud. I mean, what's the
They're-
change that you
They're not
experience?
as present. They're not.
Really?
Yeah.
And so this was the left side. Then we're going to stimulate her right side.
Let's go 6.
Okay,
It's better. It's better.
it is better.
And the hallucinations?
6 maybe.
And the hallucinations, are they still there?
Yes.
And how bad are they? And the concern regarding other events?
Other people, yeah.
Still high. Maybe. 8.5.
Gradually back.
Gone.
Yeah,
It's
there.
gone.
Now we can see.
It's
Yeah.
gone.
All right, all right. That's okay.
Okay, how do you feel now? Okay, so,
I'm seeing double.
So you can see how rapidly, some of her movements kind of return right afterwards. Now, the problem with part of this is that when we're trying to gauge response, we're using the psychosis, the rating scales, the clinician rating scales. And so we were disappointed, and this is not her complete follow-up period, that she did not, even though we thought she had a better response, and illustrated here, she did not officially score as having this as robust of a response. So that's part of the issue, is like, how do you objectively quantify psychosis? Like, how do you tell someone who's psychotic you're better? Like, they have to understand that they're better to kind of report that they are better, and they might be the last ones to kind of appreciate that. This is our third case. So he had the most rockiest course thus far, and so we did a similar process with him, and he had stimulation-related tetany as a side effect. And we're going to stimulate his left side and then his right. He did respond, however.
I'm looking to wait for him. It's better.
Better?
Yeah.
Really? So let's say it was 7.
And now we're
before.
stimulating at this point here.
4 or 5.
Really?
Yeah. I'm trying to, there's no one's there, Some of them said see you later. So,
Oh.
take care of yourself. Repeat what you said. 175. Repeat. See if it works or not. I'm saying it's not gonna work. I mean, I feel something, a little tingle, I feel a little tingle.
you seem a little restless. Are you feeling
I
restless?
feel something a little bit, but nothing.
Where?
With my hands.
Both hands? As I'm dropping
Like
down,
facial
let me
tapping.
know when the tingling or whatever goes away, okay?
Mm-hmm.
Yeah.
That's better.
Is the tingling gone or is it still there?
Yeah, that's good, I like that.
Tingling is gone.
Yeah. I like that, whatever you did.
Okay, and the hallucinations?
It's quiet, they're there, but they're quiet.
Very quiet.
They're quiet. I hear something that just, they're quiet.
And how are the hallucinations?
Better.
Okay.
Quiet, it's getting quiet.
Yeah.
Is it getting quiet?
Yeah, it's
Can you explain?
like they're on, like I I usually hear him like I hear you.
We're going to do the other side here.
And what about the voices actually?
Good right now. Still 1 and 2.
Still 1 and 2.
Sorry about the background noise. I'm running out of time. We're over here on this side now. It'll stop.
What about the voices?
Still like that. 2, 3.
Still,
Yeah.
oh, still without 2 or 3.
So he does that to try to focus.
What was that
What?
number?
Yeah. It's
What was
good.
that number? Good is a number
That's
for.
like a 1.
Why one? Okay.
Yeah.
1 with your ear shut.
Yeah. That's good.
So he had so we eventually got to a point where he felt much better from the hallucinations. So how can we be more objective with this? So I'm not gonna try to distill neurophysiological recordings here, but finding relevant signals in them is very difficult. And anyone who's interested in learning about these can go to this website over here, which has a excellent breakdown as developed by this group of learning how to interpret physiology. And so, but very simplistically, we have this raw signal over here, and we can filter the signal and process it to find a power spectra. So we can look at various peaks of the frequencies and see which one is dominant, like which, the normal alpha frequency, beta frequency, theta, and so on that we learn them in EEGs. We can filter the signal as in blue or look at its overall amplitude in red. And so this approach of filtering and getting LFPs has been used in Parkinson's disease as an innovative way, which suggests where we might go in psychiatry. So this is a person with Parkinson's. He has a deep brain stimulator placed with a motor cortex electrode, as you can see here on the MRI. He has a depth electrode getting local field potentials down in the subthalamic nucleus. He's wearing this watch, which is called a PKG watch, which provides a dynamic readout of their motor state. So persons with Parkinson's disease may be off, where they can't move, and they might be dyskinetic, where they're wiggly, sort of like Michael J. Fox. And so this is reported in Nature in 2021. They're wearing the device continuously, and it's giving a dynamic score of whether they're dyskinetic or they're bradykinetic, right? Based on this, the group gets a readout of their motor state continuously over time. Simultaneously, they're getting physiology, the power spectra analysis, either the S subthalamic nucleus or the motor cortex, and you can see various peaks showing up. So when we add all this stuff together, we have this as a trajectory of someone's given day. We can see the recordings show a beta prominence in beta frequency here in the subthalamic nucleus and maybe a little bit in the motor cortex, and then a gamma peak here when they're dyskinetic. So 2 different signatures of their motor state that correlate. So this is both deeper in the brain as well as the surface of the brain. And so since then, this sort of breakdown of these frequencies and which frequencies are relevant have been studied in a variety of indications. This is a power spectrum analysis, and you can see the different terminology for the different frequency peaks and how they've been correlated, at least in Parkinson's disease, to things like dyskinesia, tremor, rigidity, and so on. And this work has been similarly done as an objective correlation in Tourette syndrome, obsessive compulsive disorder, and depression. And so this is back to our second case where we had physiology. These are relative peaks of local field potentials from her electrode. And we can see these prominent peaks in the left SNR. And then we can see some as well in the right SNR, substantia nigra. And here we chose a relative peak at 34 Hertz. You can see that outlined here. It's prominence in the brain. For technical reasons, we could not get continuous recording of the other side. So this is just the left brain is being stimulated. But as we're escalating electricity here, we're seeing this frequency spectra reduce. And this correlates with their psychosis improvement. So this is an objective marker, we think, of her psychosis improving in real time as we're stimulating. We did not see the same effect on our initial target of stimulation on the right side. However, you can see it's maybe modestly declining as we're escalating electricity here. So we saw her in follow-up, and we continued optimizing her stimulation. And you could see here that she allowed us to reduce her stimulation. And as we were reducing her stimulation, there seems to be a burst of more activity right afterwards. So recognizing this and the lack of response on this side, we moved the electrical field lower, so, repositioned on the right side. And now when we're escalating the current here, you can see her LFPs reduce. And so the next video I have is with that insight in play of how we're optimizing your stimulation. So she had initially responded. She still kept reporting a 6 out of 10 in psychosis. Then after the Turkish and Syrian earthquake in February of 2023, she had a lot of rebound, a lot of delusional guilt about this. And so we arranged urgent follow-up and attempting to optimize her stimulation here.
Let us know this line here. Very good for, okay. Right. Do you feel more comfortable overall
This is where she was stimulated
compared to
before.
when you came in?
Yeah.
You look really more relaxed. Wow. That's good, yeah. Absolutely, yeah.
Yeah,
Do you feel restless or you feel it's better?
better,
And what about the voices?
better.
Can you comment as to
So-
how
so she-
much better?
So we definitely had an improvement in her overall intensity of hallucinations. And we'd essentially moved the stimulation field from up here down here, closer to the structure in orange, which was a substantia nigra pars reticulata. Now, our other case here, again, he had a decompensation, so we were trying to optimize his stimulation as well. And we had multiple troubleshooting visits. And as you can see pointed out here, this lead is actually on the other side of the substantia nigra. And so there's a cerebellar peduncles, the crus cerebri there, a lot of motor relevant fibers passing nearby. And so we were inherently limited by how much we can do.
Are they now? Are they getting
I'm not
quiet?
thinking about it, you know, I can't think about it. You know,
Uh-huh.
I'm so used to just thinking about it.
Yeah.
And then that's when they pop up. I'm sitting there doing something or talking to someone else, it's probably, they don't have time to talk, you know? Like I'm talking to you, I can hear them. You're talking to
Yeah.
me, I can't
Oh,
hear
you
'em.
know, just quiet.
But if I sit here quiet, piece of quiet,
Okay.
I'll probably hear them.
How do you feel?
I'm talking to them in my head right now. I can't concentrate. I didn't hear one word you guys said. I was sitting here kind of, because the concentration's out the door to me. I can't concentrate nothing.
Yeah.
Just see them talking and stuff like they're gonna, like, all right, Jenny, well, I'm leaving. I'm like, yeah, okay. Where you going? In your car that you have?
This is after programming. You know, he appears improved. He's unconvinced though. And so, I mean, that's part of the difficulty is their recognition of their improvement as well. So this is from our programming tablet. The physiology that we're getting here is from these electrodes. And because it's outside of the substantia nigra, we can't get as good physiology, particularly from the left side. And we think that might be partly why. He had a surgery done right before directional steering technology was approved for us to use. So he's actually under consideration of lead implantation here. And so this illustrates, as we are attempting to escalate his current, we're not having as much of a robust change. And this sort of confirms why, he wasn't getting as robust of a response as we want. So since then, we've been attempting to kind of troubleshoot why this might be the case. These are structural tractography maps that I'm not going to belabor here, but we can see in our first two subjects that, perhaps the thalamic connections are a bit higher up in here, whereas if you look at his tractography map, you don't see the ventral anterior VPL, the thalamus being as high up. Perhaps that's relevant. We're not entirely sure. That's still preliminary data. And we're also attempting to develop digital biomarkers. So this is from our neurological signals paradigm, where we're training an artificial intelligence to essentially decode signatures of cognition and movement. So we have a tablet that does infrared recording of saccades through this. We have a microphone that records examples of speech. This is its setup in the clinic space. So we record subjects. We have about 300 plus Parkinson's subjects, but anyone undergoing DBS. And this is how we essentially do feature extraction, which is relevant for the biopsychosocial seminar coming up next. I'm collaborating with a team of engineers where we get raw signals from eye movement, speech, handwriting, and so on. And then we will clean the data, abstract relevant features that we can understand, like where is the eye, how is it fast to move, how loud does someone speak? And then recursively, we can have the artificial intelligence extract more meaningful conclusions out of this. And so this is an example of our third subject before and after stimulation was done on how performance of the cookie theft. You can see how his eyes are moving up here or how he's doing on a Stroop model task down here. And so you could just looking at this, you can see his performance on the Stroop is much better on the bottom right as, as the stimulator is on. And so this is still preliminary data. We're doing further analysis, but we're hoping that this correlating with our local field potentials will be a better way forward to kind of objectively look at, DBS. So sort of in summary, a couple of summary slides here. So DBS is a process. It's not just a procedure. The effective implementation requires a kind of a systems level thought. You're not just worried about what's happening and where you're stimulating of what circuit is doing. You're looking at what are the downstream immediate effects in that circuit network, and what are the larger scale brain network changes that happen, right? And then you use that initial data, this initial observations that you get, to test hypotheses and to kind of become better at outcomes generally. You can do local field potentials in the target. You can look at different study sites and optimize where you're stimulating and look at whole brain networks, and ultimately go back to the operating room and kind of optimize how people are doing. And so despite the fact that I only reviewed 3 cases, we're optimistic about moving forward. We have a UO1 that has now cleared 6 additional implants as of September. And so if anyone has interested, patients, we're happy to see them. So none of this work would have been possible without my colleagues over here, especially my research assistant, Seneca, who's been miraculous, is Nicola Casella, who's the PI on the protocol, Stan Anderson, our neurosurgeon, and Kelly Mills. And as I said, thank you very much for paying attention.
We have some questions online. Do we have any questions in the room?
What do you think happens to anything at the point of the electrode when you inject the current?
Oh, so there have been studies done. So the question was, what happens at the point of the electrode? Like, does it actually damage the brain? So there have been autopsy studies done on persons who have Parkinson's disease to see what happens. And there's very minimal peri-lead change using at least modern settings. There are upper limits. And that piece is perhaps under debate by small groups, but modern leads have upper limits on the amount of electricity emitted to protect the brain structure. So we don't think there's direct destructive processes. Now, on the other hand, there are select cases where just the process of putting a lead in causes idiosyncratic inflammation, and we see like this edema, but that's very, very uncommon.
Then what do people speculate is the mechanism of action?
Oh, that would take another like 4 or 5 hours about how DBS actually works.
Oh, give us a little hint.
Very simplistically, we used to think it would be as simple as you dump a bunch of electricity in, it hyperpolarizes the region, so it mimics a lesion. That's not true. It doesn't do that, or at least that's not how it really works. In modern theory, we think the amount of electricity we are emitting in a radius squared diffused area around where the electrode is selectively gates what elements are stimulated, what elements are not stimulated, what normal activity goes. And so at least in the Parkinson's realm, we basically release the brake that's present in the subthalamic nucleus, allowing normal motor activity to occur. Whether that same model is true in other diseases like schizophrenia, it's unclear.
Are the neurons in the area hyperpolarized or depolarized? I mean,
So
do you have any idea?
They're in dynamic states. So
While the current's active.
yeah, because the current is not
Okay.
on continuously. It's sort of being turned on and off at a certain frequency every second.
Oh.
Doug? Oh, sorry, go ahead. Yeah, so I couldn't explain. So in all 3, we have started reducing their medication. We were able to reduce the first subject's Haldol dose by 50%, and that allowed us to reduce her anticholinergic exposure. The second subject, we were able to reduce, I think she was on quetiapine, and so I think she's had at least a 200 or 400 milligram reduction of her dose overall. So unlike all the other sites, we're actively attempting to reduce the amount of medication that they're taking to simplify their regimen overall. But yeah, that's a good question. Sheldon?
Congratulations, by the way. Local boy makes good. That's good to see. Why did you come to the pars reticulata because you've done so what Helen Mayberg did with depression, she took a place that was hot on fMRI, says, let's put an electrode in it and stimulate, but it was a white matter crossroads. Yeah. And it was very hard to say what was going on, right? So now you're going into more of a gray matter and white matter area. Why pars reticulata for schizophrenia? What led you to that?
So it wasn't my choice, is the truth. I didn't choose that target specifically. But the theory was that the dopaminergic projections there might affect the medial dorsal nucleus, the thalamus, and that might direct impact the circuit of hallucinations. The point of fact is we see very little structural connectivity to that area. And so now we're trying to figure out how the heck it's actually doing what it's doing. So serendipity, we're not sure how it works.
The other thing that Helen ran into trouble, she had her first 6 cases, she showed videos. They were miraculous.
Yeah,
But then the Broaden study didn't reach critical,
right.
and there was all sorts of reasons why it failed the
Right.
test. But so it's a little iffy to show videos in early on. It builds up a lot of hope, obviously. But what's your comment about
Well,
that?
true, but I will say that there is a difference in how we as a human interpret someone's response versus the accuracy at which a scale can encapsulate said response. And I think that when we're doing a study, you have to formalize all these elements, to kind of remove noise, but it also removes some subjective, indescribable aspect of what you're seeing that we all sort of develop a skill for when we're in the room with patients. And so I think that's the utility of at least showing videos. I can say that the first subject is stable for 2+ years now. Our second one, after we did further programming, she's now at 19 months since reprogramming. She's back to work. She's doing, very well. Like we'll have to follow them up longer to see, but yeah, your point is absolutely valid.
One of the things about the Broden study was it was not done with with MRIs in the operating room. And so the techniques have become more modern.
Yeah.
Helen Mayberg believes the neurosurgeons didn't always put the electrode in the right place.
Despite their state.
But anyway, question from a former neuropsychiatry resident currently based in Hawaii. Dr. Janetta Brahma was asked, was there any noticeable improvement in her functional weakness? I'm not sure which case she was referring to.
She did not have any weakness at the time of her initial, that was in the past.
It was in the past.
It was in the
okay.
past, yeah.
You're saying that the situation.
No, it's in part, well, no, they're all three, I think, part of reticulata.
Yeah,
Yeah.
Or-
different areas.
Yeah.
Oh, no, that was in depression. In Helen, the one he was.
Use the
quoting a
mic.
Series of cases in the original, where they put electrodes into the fracture depression. That was a hotspot found on MRI studies, but it happened to be in a white matter prostate. This is more securely investigated.
Taylor?
Yeah. 2 quick questions. Do you distinguish between auditory hallucinations from an external source versus an internal source? And 2, did I see some hemispatial neglect on that cookie theft?
So I'd have to take a look at that cookie thefting. I don't believe so. The saccade reading doesn't quite come across on the video as well. So that's one. The second thing is, no, we don't distinguish between the source, but perhaps we should. Dr. Barrios.
This is a visiting neurologist, you see how I just actually wondering in terms of the neurologic effect, and because it's this area we use it in Parkinson's too, because it's abnormal, and here you're stimulating a normal area, and I'm actually surprised that yes, that I've only seen one patient with
we are hoping
tetanus.
nothing happens.
Yeah, and do you expect it to see a little bit more in terms of hemimalismus or more tetanus or more abnormal movements, or like?
So I'll do so the question was, are we seeing side effects of the stimulation in that area? And short version, I do regular Parkinson's exams on these subjects routinely. So I'm not getting any change in their motor performance. We actually initially speculated where akathisia was worse with stimulation. Coincidentally, and unrelated to this talk, every single one of those patients had an iron saturation at less than 15, which is ridiculously low. And so they're all getting iron infusions now. And so we're going to see whether they actually truly have akathisia related stimulation, or if you weren't aware, as of 2018, the main intervention for restless leg syndrome is evaluating iron status and giving an iron infusion to correct the underlying deficiency. So I'll get back to you.
All right, one last question from online from Dr. Alexander Lichtenberg. When you evaluate for treatment-resistant schizophrenia, what steps do you take to ensure the correct diagnosis and to screen out incorrectly diagnosed patients?
So this is both by chart review. They have a structured clinical diagnostic interview. They have to meet criteria of the SCID. They have to have 2 psychiatrists evaluate them, and then they have a separate capacity assessment. So this is as good as we can do.
All right, thank you very, very much. Very interesting.